Good evening, everyone, and welcome to the 26th monthly webinar. My name is Danish, and I'm a product specialist at Collective Minds Radiology. Thank you for everyone that's joining us this evening, and I hope you're all enjoying this hot weather in the UK anyway. Tonight, I'll be joined by no other than Dr. Imran Lasker, who'll be presenting around 12 to 13 cases varying from CT, MRI, and plain film. We also have a donated case that we'll be sharing at the end as well. And if you want to donate a case for any future webinars, all you need to do is just at Doc Lasker on the platform on Collective Minds. So if you ever upload a case onto there, if you just tag him in onto the case, he'll be able to review that case in the upcoming webinar. I am going to share the collection so you can follow along during tonight's webinar. There'll also be a couple of poll questions popping up during tonight's session. And if there's any issues, just contact us on support@cmrad.com, or you can also use the chat box as well. So I'll just share those collections with you now. So there's actually two links that I'm going to share. So those that don't have accounts on Collective Minds can also access the collection tonight. So just use the first link if you don't have an account on Collective Minds, and then use the second link if you are a registered member of Collective Minds. And finally, there'll be a CPD certificate for everyone that attends tonight. So just remember to fill in the feedback survey at the end of the webinar, and I'll send the link for that as well. And I think that's about it. Over to you, Dr. Lasker.
So hi, everyone. Welcome to another webinar. Hope you're doing well and having a great time. In the UK right now, it is very, very hot and very, very sunny. For us, I guess hot is 29. I know that. A friend of mine just came back from Dubai and they're saying we don't know what hot is until you go to a country like that during this time. So I hope everyone's well. I am going to be opening the chat function. So as usual, I will be keeping an eye on the chat. If you've got any questions during it, or if I get anything wrong, then do feel free to come at me. It's fine. We're all here to learn, hopefully just get through some cases and just enjoy a bit of radiology together using Collective Minds Radiology platform. And as usual, it kind of goes between difficulty of cases. Some cases are very straightforward. I get it. Not everyone will find some of these challenging. Some are a little bit more challenging. I try and keep it interesting for everyone so that everyone gets something at least from the talk. So today we're going to start off with case number 1. And what we can see here is that this is a X-ray of a hand. And so what we need to do is, what I'll do is just sort of open this one in the beginning, just have a good look around and see if there's anything grossly abnormal anywhere. So let's see if I can get the pen function out. Okay, cool. So this is working. Someone was asking about this, so I thought I might as well bring this up. So I can use my iPad to be able to actually draw while I'm talking to you guys. And so what I've done, I've got a Mac and I've extended the display onto here and then use the pen, and then I can actually press B and then use that to draw around things as well, which is really, really good. And also use my hands to sort of zoom in and zoom out if I need to. And then E actually just gets rid of the entire thing as well. So I think it's a really good platform, and I use it for my live courses as well. Okay, so let's have a look. Has anyone seen anything just yet? No one's saying anything. So what I always do is try and have a look at the carpal bones and just make sure I've drawn around it, especially that scaphoid bone, because you can get proximal, middle, or distal polar injuries. But it doesn't look like there's anything like that here. And then you've got your lunate, and then you've got the rest of your bones sort of going across like this, and they all actually look okay. And then there's something called light of day sign that I've seen being described, where you try and imagine that there's a light behind here shining this way, and you should be able to see some light going all the way through here. But that looks like it's quite well maintained. So we're not looking at anything that looks like a dislocation, a translocation of any of the carpal metacarpal joints. The next thing I'd always do, if I do have the images, I go to the fingertips, but this is not really a hand X-ray, it's more to do with the wrist. Have a good look at yeah, good, well done. So then also we'll have a look at the metacarpals, and sometimes we've had a case actually been donated to us. We actually had some really nice hook osteophytes. If you do go to previous cases and stuff, you will see there were some really cool osteophytes that came up. But this one looks okay. There's no fragmentation, no erosive changes anywhere. But someone has said that they can see something located within the distal radius. You are correct. And I think it was actually initially missed by the initial reporter. And when you kind of look at it, you do feel as though there is something a little bit abnormal about this area over here. And yeah, you kind of get a bit of a protrusion in some areas, especially where the growth plate used to be. And normally the growth plate would be somewhere around here, and you can get a little bit of a kind of calcification on that end, or just a bit of a protrusion. But this one looks a little bit more faint. And then in the middle of it, there does look like there's a bit of a linear radiolucency located within there as well. So when we zoom in, hopefully you can see that, yeah, there is what looks like a linear radiolucency over here. It almost feels like this linear radiolucency goes all the way along like this, all the way along like so, and all the way along like so, right through to the articular surface. So this is kind of yeah, this is not normal, and you can see that normally, a kind of growth plate wouldn't be like that. A growth plate would go across like this, not all the way across to the articular surface like this, and you can almost imagine the lines going all the way along like there as well. Let's have a look at this sort of view as well, and try and see if we can find exactly the same kind of fracture thing that we're worried about. And yeah, there again, you can see that if you draw along the posterior cortex, which is going to be around this area over here. You can see there's a bit of a kind of bump over here, and then it kind of carries on, but it's not so easy to see that growth abnormality that we saw earlier. The thing is, this bit here that we're looking at earlier, if we kind of zoom in and zoom in and zoom in, what is that? So that means that this person's had a little bit of callus formation. So this is not like an acute injury. They've had it for a little bit. Maybe they tried to rest it, try and ignore it, and then the body's tried to heal itself as best as it can, and you've ended up having a little bit of callus formation just around that area over there. And then when you actually would do a CT, you may see that there's a bit of bridging callus formation in some areas, but not all areas, because predominantly there's still a radiolucent area over here. So anyway, I think this is quite a good case, especially one to begin with, just because at first glance, it may actually look okay. You might just run through it, especially when you've got a big case of images that you're working through. Okay, so here's another sort of, I wouldn't say bread and butter case, but a case that we should hopefully not miss. I always have a system with these things. I always try and make sure I have a good look at the metatarsal heads, because sometimes you do have avascular necrosis. Once you've done that, you do want to have a look at the metatarsal necks as well, just to make sure there's no evidence of any hairiness or any sort of furriness to suggest that there's any sort of underlying stress fracture. And they can be really, really subtle. And anyone that's been joining us for a few of these now, you probably know how subtle these things can be. So I really do zoom in like this. I have a really good look around just to make sure there's no evidence of any sort of irregularity at all at any point. And actually, when you go along this way, go along this way, go along this way, these all look very, very smooth all the way through. So I can't say that I can see a fracture there at all. Next place to look at is going to be the base of fifth, right? So base of fifth is very, very common. Sometimes you can get an oscal, so just be careful. Don't get put off. Try and make sure that if you do think you see you've got a fracture, make sure that you can see that it doesn't have a well-corticated contour. So what I mean by a well-corticated contour is that when you look at this line, you can see it gets slightly more dense as you get further and further towards the edges. But here, this is actually normal, obviously, and you see some vascular planes and that kind of thing that have very well corticated areas. But if you've got a fracture, that's when you don't have much cortication because it's been newly introduced to the body. The body hasn't had time to react and become part of its normal anatomy, and you see a fracture. But this one looks okay, doesn't it? I don't think we can see a fracture. And the next big tip, or actually, yeah, that no pun intended, but ended up being, I guess, a pun, is I look at the tips. I look at the tips of the toes and just make sure there's no fracture. And be very, very careful. Always draw around the nail and make sure you can see the nail and then look for a fracture. Because often people may start worrying that there could be a fracture when actually it's just the nail bed. So make sure you draw around. And I think I might have said recently that there was one point that I thought I saw these calcifications sitting within this region over here. And I was convinced it was some sort of calcium deposit, and then I suddenly realized actually they probably just got their nails done and they've got these little kind of nice jewelry things or things in there. Please don't hit me, I don't actually know what it is. I've got no clue. Right, so sesamoid bone someone's mentioned. Yeah, so yeah, I am very, very reluctant to call many things on the sesamoid bones when it comes to x-rays, unless it's very, very obvious. And when I say very, very obvious, it has to be something along the lines of very densely sclerotic, maybe tiny, tiny fragments compared to the other side as well. It's got to be very, very abnormal, or there's got to be a lot of soft tissue swelling. But this one, yeah, it looks okay. I don't think I can really call it. Next thing you want to do is make sure that everything is nicely lined. This is probably the better view to do it with. You zoom in, zoom in. And what I mean by nicely lined, you want to make sure that the space of the second metatarsal nicely aligns with the sort of middle cuneiform over here. Because if it's shifted across, you've got to start worrying about something like a Lisfranc injury. But yeah, someone's seen it. Well done. There is an abnormality located somewhere else, which is not actually the foot. So let's have, well, it is the foot, but kind of not at the same time. You can see the calcaneum. That looks okay. But when you go to the other view, let's go to zoom and then just pan this across to here. Yeah, people have said it. Yeah, well done, well done. So you've got to try and make sure you look at absolutely everything. Now, this is our job as radiologists. If there's a lung cancer at the top of a C-spine CT, it's your fault. If there's a lung cancer at the very top of a chest abdo pelvis, it's your fault. You know what I mean? And so you've got to be very, very careful and make sure you looked at the calcaneum. That's one thing. We'll look at the the tibia plafond, and also look at the lateral malleolus, and you can see, yeah, there's definitely a fracture there. So this is quite a classic case, and actually put that much higher in your checklist when you're looking at these sort of X-rays. Make sure you have a good look at the areas that, the way I try and say in my mind is look at the areas that most people won't look at and look at those first, and then you go on to actually looking for the big abnormalities that are a bit more kind of not so subtle, or the kind of check areas that you would expect to do. Okay, so well done. Let's download these images. Okay, so don't know what that's about. So let's download these images. Okay, let's have a look here. So I would recommend download the images because it just makes things a lot smoother, especially when I do the teaching. It's really, really good. People get to just zoom through the images without feeling like they're being lagged behind. I'm full of puns today. I don't know what's going on. I'm on form. All right, so let's have a look at this X-ray and see what's going on. So at first, it looks okay, doesn't it? I don't think we can see anything grossly abnormal. I know we've got a CT, so you're kind of thinking, oh, I want to get to the CT. Now, for those that do watch this, I do know that some of us are here and you're going to be doing 2B exams. Now, and if you are, let's say, doing an MDT, one of the tricks of an MDT is to really kind of demonstrate your knowledge. And one of the ways to do that is to try and demonstrate how much you can get from an X-ray, and then almost try and predict what you think you'd see on a CT scan. And that's what you'd want to do on your 2B, on a 2B exam or any sort of radiology exam. What I often find with the candidates that do enter the teaching is that they will get an X-ray, and then the next thing in their mind is that they just want to get to a CT, and they kind of half justify it. They'll make up something to try and justify some sort of CT, and they'll say, I want to move on to a CT, but they won't actually say what they're expecting to see on the CT scan. So very, very important that you try and, if you're doing this in an exam situation or even in MDT, try and say, I'd get this and this is what I'd be expecting to see. And that kind of just gives you a little bit more, it just kind of puts you a bit further than other people are, in my humble opinion. Right, so let's have a look at this X-ray. And at first we have, oh, sorry, I zoomed in. Let's go to the pen function. And these looks nicely inflated. There doesn't look like there's any hyperinflation or hypoinflation, which is good. Lung markings, yeah, you can see lung markings going all the way along, all the way along. So that's also good. I'll always do my check areas. So look at the costophrenic angles. Okay, they all look good. This area also looks okay. Doesn't look like there's anything grossly abnormal. Running out of things to be looking for here. So let's try and zoom in a bit and do a bit of zoom and pan. So let's pan and zoom around. So always good to look at the lungs, look at the lungs, look at the ribs, look at the ribs. And I genuinely would draw around each one. And I know it can get a little bit hazy, but like I say, try and call obvious things. So if you're thinking, oh, that looks a bit irregular, but you're not convinced, that I wouldn't really call it, right? Just try and look at the ribs, try and look at the ribs. Make sure you can see what's going on the ribs, and they all look okay. Clavicles look okay. There's no abnormal dislocate. There's no dislocation or fractures. Sometimes you get some subtle ones there. So at first, right now, it looks like everything's okay. And I think everyone else is also a little bit stumped as well, most likely, unless you've gone across to the CT. So what we'll do now is try and draw some normal anatomy. So we can see that the aortic arch is there, and you can see that that goes probably down that way. You can see the cardiac border going down this way, but it does feel like there's a bit of a density that is located over here, which is kind of extra, right? Because you can really, you can explain this one, you can explain this one, but not so much on this one. And it can be a little bit difficult to really convince you, but if we kind of do this and try and window a little bit, you can actually see that there is something a little bit more dense located just behind that area over here. So well done. I think someone has picked it up, that there's something going on. We said, yeah, obscuring the descending aorta, exactly. So now we thankfully, hopefully by now you've downloaded the images and should be smoother. And what we'll do, I always do, oh yeah, the other thing I always do is stay silent and do one scroll through and just look for like kind of more subtle stuff. So I always go back up, and then come to what I actually think there is what looks like a radiopacity located within the left lower lobe. Now, I brought this case in and I've just noticed something. Has anyone else seen this? I might have to go back and see what they reported, because there's something hyperdense there, isn't there? But what is that? Because I don't think they've been given all contrast, have they? Why would they be? Coming further down, I can't see any oral contrast anywhere. I mean, it could be a medical pill that's got stuck there, I guess. Let's have a look. So what I obviously, I mean, for those that know, I really like collector mines because you can do all this stuff just like you would on your pack system at home. You can really manipulate the images and really have a good look around and see what's happening. And that looks, is there a perf or foreign body? Yeah, that's what I'm concerned about actually. Is there a perf or a foreign body located within the esophagus? And it does feel like there is some hyperdense material located within the esophagus, and there's also does feel like there is a bit of fluid located within the esophagus as well, and that consolidation. So I guess you could end up having a situation where someone's ingested something, it can result in a perforation. I'll have to go back and find out, but it does look like there's a few linear hyperdensities located within there. Yeah, I was thinking contrast too, but where's the rest of the contrast? Because why would someone just have a few drops and leave it there unless it's within the stomach, but it's not in the stomach and it doesn't look like it's anywhere else. And I don't know why they would do an abdo-pelvis with, why would they do a contrast study? So anyway, at this point in time, we don't have any enlarged lymph nodes, but we are worried that there could be something else going on with regards to the esophagus. It could be an ingested bone, yeah, potentially. I've actually seen something like that, but a bit further down where someone has eaten a bone and has gone and perf, like right down the sort of ileocecal valve area, because that's where it ended up getting lodged. So quite interesting case, actually. I might try and find out what exactly happened with this patient from the clinical notes and stuff. But anyway, I thought it was quite good because of the retrocardiac abnormality that was actually been able to be identified on the X-ray. Okay, so good, good. Let's have a look at this next study and try and remember what this one was about. All right, so let's zoom in. And this is a plain film X-ray. And actually, you know what, interestingly, recently someone was talking to me and saying I don't do very much MSK. So I did try and bring some MSK to the table today. And let's have a look. Okay, so we're looking through here. I haven't seen anything grossly abnormal. So again, what I always do is try and draw around every single bone, like every single bone, every single metacarpal head. I try and draw around it. Here, I'd say there's a little bit of loss of joint space there. Don't think like it looks like there's a bit of loss of joint space. The other place to look for loss of joint space would be the base of the fifth metacarpal as well, and the STTJ. Just over here as well, you can get some loss of joint space, probably because we're all spending so much time on our phones these days. Let's have a good look around. Let's have a good look around. So someone said rheumatoid arthritis. Yeah. So rheumatoid arthritis would basically be sort of the carpal bones, the metacarpal bones, and you'd have like radiolucencies or that kind of thing to suggest there's erosive changes or maybe some soft tissue swelling. I don't think I can see anything like that here, but you know what? It's actually catching my eye, and I don't know if you guys can see that when you kind of go beyond the X-ray, but there is a plaster that's there. Can you see that? Someone's put a plaster over here, so there might be something going on over there. So let's zoom in and have a look and see. Yeah, it looks like there's a bit of something missing there. Can you see that? So if we go there, you can draw. Normally they can look like little hats, but this one looks like it's a bit of a loss of cortex located within that region. Let's we can get some better views of this and see what's happening because at this point I can't see a displaced bony fragment. Difficult to see a bony fragment. Let's zoom in a bit. What else, everyone? Is anyone else seeing anything? I mean, there's a bit of this density here, but it doesn't really convince me to think that there's a bony fragment here. And this actually looks a little bit abnormal, like maybe it's been eaten away. So let's have a look here and see if we can zoom in. Or maybe it's been pushed underneath. Sometimes you get these fractures. Oh, maybe it's displaced. So I think it's actually just just a fracture. It's not great, is it? They probably smashed their hand in a car. That almost happened to me the other day. But anyway, my hands are fine. Right, so we can see that there is you can see that the tip, look at the base, it looks quite impacted on one another. And there is sort of radiolucent that extends all the way down to the articular surface bowl. So it looks like quite an extensive fracture. Most likely been shut on the door and has resulted in that horrible fracture located there with some articular surface involvement. So I think that's actually a traumatic injury. Yeah, I would think is jammed by the door. Yeah, I think that's probably what's going on there. Not a great injury, makes me flinch actually, honestly. Right, okay, so let's have a look at this one. Again, what we'll do, we'll zoom in. I know we'll download the images first and have a good look through. I hope you guys, I mean, have you guys been able to, let me know what you guys think. Are you guys using Collective Minds at all? You guys running courses as well, sharing case with your colleagues? I think for us, it's really helped us. Basically, yeah, run our business, the lecturing business that we do. For those that are interested, it's called Radiology Seminars. Right, so let's have and I recognize some of you guys from there as well. So I appreciate the support. Right, so this is a CT head, and let's have a good look through. Okay, well, let's do one scroll through, and if anything pops up, feel free to write something down. Okay. don't think I can 100% see. I saw anything first glance. Oh yeah, okay, good. There is something there. Where's anyone see anything? Okay, so when we come to the top here, it feels like there could be a bit of a subcutaneous hematoma located over here. Don't know if anyone can see that, but just look, there's a bit of extra soft tissue swelling located over there. The first thing I'd do is to check immediately underneath this area, make sure there's no blood there, and also check the ache for a contrecoup injury somewhere over here, just to be sure that there's no sort of bleeds anywhere. So as we scroll through, let's scroll, and there. That bit there doesn't look quite right. And actually, when you look at it, there does look like some bit of a radiolucency just around it as well, just around it. So that must mean there's a bit of edema. So this would probably be a bleed, a very, very small bleed located within this region. Not the most common place to have contusion bleeds, but they can happen. Some of you may think that maybe this is the bleed here, but actually when you look at that, it's very, very linear and goes along like this. And so actually that's just a vessel kind of carrying along on the same plane that we are in at the moment. Okay, so let's keep scrolling through. So there's a bit of blood located there, we think. So we're probably thinking a bit of a contusion bleed. And the next places that you get contusion is going to be within the temporal lobes and also located within the frontal lobe as well. And I just wonder whether there could be a little bleed located just over there. So one of the ways that we can try and have a closer look is to actually do a little bit of reformatting and have a good look and see whether we can actually find any bleeds anywhere else. Have a look. Don't think I can convincingly 100% say that I can see anything in the frontal lobes. Maybe just there, actually. Yeah, look at that. You can see these. I'm going to just draw that there, little tiny ones there. So very, very common. You know, when you get these acceleration, deceleration injuries of your head, there's parts of the brain that kind of hit the front and hit the back. And I was actually thinking about this the other day. I think, what was I watching? Something about Amir Khan, the boxer. And yeah, these guys must be walking away with contusions, like loads of them. You know, I just don't understand how that sport continues, to be honest with you. But that's just me in my old age. Maybe, I mean, I don't get me wrong. I used to really love it when I was a kid, but these days I don't think I can really watch it. Okay, so now when we go to the bone windows, what we'll try and do is it this one? Yeah, go mist oblique. Yeah, you saw it. Yeah, you saw it straight away. I'm going to show you the trick that I always try and show people. I think is super awesome, and I don't know why people don't use it. You do this, you window, you see, go to MIP, you window a little bit, and then you scroll through and you can see that, can't you? If I double click, there looks like there's a fracture there. And, you know, adults don't have metopic sutures. And this one looks like, let's just try and do this. And what I find that you can actually really, it's really nice to manipulate things as you go along. So if we do this, you can manipulate that, but keep your eyes on this one over here. You can keep your eyes there and keep looking, and just move it along. And you can see that, yeah, there's definitely what looks like a fracture. And I find that so much easier as a way to look for fractures than anywhere else. So yeah, it's okay. I mean, you can watch it on the recording. I put it on YouTube soon anyway, and you get a recording link afterwards. Okay, so yeah, so this one we've got a subcutaneous hematoma. We've got what looks like a contusion bleed adjacent to the left anterior falx. And we've got a few contusion bleeds located within the frontal lobe. We don't see any significant mass effect, but they've also got a skull fracture involved in the frontal bone as well. Okay, good. So let's go on to the next case. So this is an X-ray of the foot. Can't remember why I put this in here. Let's have a look. Zoom in. Oh, sorry. Let's have a look. How do I get rid of that? Oh, it's on my iPad. That's why. Okay, let's have a look and pan around. Okay, so we've got some increased cortication located within that region of the first metatarsal. So what does that mean? So we think that, I mean, that doesn't look, it doesn't look aggressive, looks benign. It could be, I mean, sometimes you get some melanostosis, bit of an odd place to get melanostosis, to be honest, but it can happen. Can we see any stress fractures anywhere? So let's zoom in a bit and try and see what we can find around. So no stress fractures. So what I'm doing here is trying to look for the metatarsals again, make sure they all look okay, but I can't see any stress fractures anywhere. No loss of joint space, no fractures there. Terminal phalanges, they all look okay. Base of fifth looks okay. Okay, let's have a look at this side then. Let's look at another view. So no lateral malleolar, no tibial, no calcaneum, cuboid, all looks okay. Has anyone seen anything on this one? Okay, zooming in, have a look, have a look, have a look. Well, I put this one in by accident. I feel like I didn't know. There must have been a reason I put this in. Let's have a look. Okay, let's go to the next view and zoom in and have a look around. So let's have a look. So we've had, oh yes, okay, got it. I remember now. Right, so let's have a look here. So the bones actually all look okay. When you're looking at this, the bones all look okay. They don't look too bad. And then when you look at the articular surfaces, they all look okay as well. It doesn't look like there's any articular surface abnormalities. No base of fifth fracture as well, because yeah, no base fifth and no stress fractures. And there's no evidence of any Freeberg's and fraction either. So Freeberg's and fraction would be that sort of fragmentation, loss of cortex there. But actually, this is more about the soft tissues. Okay, so the soft tissues here, if we come up to this one and we zoom in, they've got a piece of glass sitting right located within the heel pad, just sitting over there. So this was an X-ray looking for foreign bodies, and you can see that this is a radiopaque piece of glass. Maybe someone can remind me. Someone was telling me, and I haven't looked it up properly, but there are some bits of glass, some kinds of glass that are radiopaque, and some kinds of glass that are not so radiopaque. But anyway, this one in particular is very, very radiopaque indeed. And I remember I had someone come in to ultrasound, and they kept having foot pain and they couldn't understand why. And then there was a massive, honestly, I was really shocked at how big this chunk of glass was, and I could see it. And then she was like just walking on the beach, and she stepped on some glass like months ago and just walked around with a bit of glass. I don't know how she did it, and actually I don't know what happened to her foot in the end, but she seemed pretty well otherwise. Okay, let's have a look at this one. It would help a lot on that one. Yeah, it would. It would. Yeah, and I actually forgot what the history was. Sorry. Okay, so let's have a look at this one and see what's going on. I don't know if how many of you guys have done like the FRCR, but like the FRCR, they've got this like rapids exam and there's like no history whatsoever. Oh, honestly, it's like just walk in the dark. It's just you've got to look at everything. And that's when check areas become really, really useful, to be honest with you. Right, yeah, so let's have a look at this one. So at first, you might say, not much going on. Looks like it's relatively okay. I'm not particularly worried. The lungs look very, very good. You know, the lungs look very, very clear. There's no evidence, yeah, everyone's going for it. There's no evidence of a pneumothorax. Now, this is quite good. Like we've got aortic arch, you've got the cardiac border. You can't really see the descending aorta so well, but there's no added density like we had with the other one. The bones all look good as well, and we can't see any fractures, no stress, no dislocations, anything like that. But yeah, everyone's saying it. Yeah, right there. Yeah, just messages are flying in. You can see that there is a little bit of radiolucency located under the hemidiaphragm. Now, what should really happen is that you got your liver, and then you got your diaphragm, and then there's no interface between them, and then you got your lungs. So as soon as you get a bit of an interface between them, i.e., air, that's when you've got to worry there could be an underlying perforation located within, or there's some sort of perforation or perforated viscus located around. So this is clearly something we need to kind of delve into a little bit further. And so what we need to do now is, oh, hang on, what have I done? Let's do that. Is go across to the CT scan. So the CT scan is here. Let's download the images. Download. Oh, it's going rapid. Okay, let's have a look and see what's going on. So let's go from the very, very top and find out what's going on. And I would actually be interested to know what people would say in this particular situation. So, okay, look, we've said pneumoperitoneum, we've found some air within the abdomen. So where can the air from the abdomen come from? So my first bet would usually be the duodenum, right? That's very, very common with the sort of air within the upper abdomen. So you can follow the stomach, follow the stomach, follow the stomach, follow the stomach, coming down this way, coming down this way. This is the duodenum, and I don't think I've really seen anywhere on the stomach, and I haven't seen anything along the duodenum. Nothing along the duodenum there to suggest there's any sort of perforation or fat stranding. Okay, so maybe we have to say that we can't see anything grossly abnormal located there. So we may need to go right from the very bottom, quite literally, go from the top, the bottom here, go all the way up, sigmoid colon this way to the descending colon. We'll follow up, 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 all the way to the top. Go across the transverse colon to the ascending colon, all the way down to the cecal pole. Where's the ileocecal valve? It should be the one with sort of the fat around it. Can we see the appendix? I always encourage people to look for the appendix if you can. Oh, it's not an easy appendix to find it if you can, is it? It's not an easy one. See if I can find the appendix. Hard one. Might be somewhere in this area here, but oops. But anyway, so yeah, I don't think they've had no biopsy, they've had no procedure. They came in with excruciating abdominal pain, so no post laparoscopy. And someone said it when you've got just air and no source, um, I generally just describe it and say, look, there's a few. Oh yeah, we haven't actually shown the air, have we? So let's go to lung windows. So just press number 4, and that'll take you to lung windows. And you can see the little bit of air there, a little bit of air there, a little bit of air there, just sitting on the on top of the liver, you see. But I can't really, and so sometimes you'll be able to find like a little focal area of air, but again, you can't see any focal area of air anywhere on this where it's all coming from. So in that situation, I'd say there are multiple locules there located within the upper abdomen, and hang on, someone's saying there's found an opacity somewhere. Let's see. Small opacity in the liver next to the IVC. Let's have a look. So IVC would be this guy here. And there's a little bit of a high density. So yeah, I've seen calcifications located there. I don't think it would be related to whatever's going on here. So yeah, fair enough. There is a what looks like could be a benign, I'd say, calcification located there. If you're concerned, you could do an ultrasound, but you probably just get post-echoic shadowing if you can find it in the first place. But I would say that when I write this, I would just say that there's air located in the abdomen. I haven't seen an area of perforation. If it's a clinical concern, they may need to have direct visualization. They may need to go in and actually look and see whether there is a recent, like an ulcer that's kind of sealed itself off. But like someone said earlier, it may be a sealed perforation, so it's basically sealed itself. Sorry, it's a bit cold in here. I'm gonna put that off. Okay, cool. So that was what I thought was an interesting case, and no real clear answer for that one at all in the end. Right, so how are we doing for time? Because we've got quite a few cases. Did you get incomplete histories in requests? Yeah, all the time, and that's part of the job, isn't it? All the time. This one was just 2 days of excruciating abdominal pain. And, it may be useful to know if they've had any previous procedures, like people asking. It may be useful to know if, I don't know, if they've got peptic ulcer disease, they've got heartburn in general, that kind of stuff. But I'm not, I completely understand when you're running around in A&E, you've got so many things to do. It can be hard to make sure that you write the right thing. At that time, you're just trying to get the right scan or get a scan in the first place. So we're all under pressure, aren't we, to be honest with you, in the healthcare system. Well, in the UK anyway, it's not great. For those that don't know, my dad actually ripped his Achilles tendon, and I ended up in A&E for literally 12 hours. It was just horrible. I felt really bad for him, but he's all right now. He's in cast, and hopefully that's going to be fine soon enough. Okay, so let's have a look at this one. And yeah, so you could do a contrast enhanced study, give them some contrast, and then just see whether the contrast ends up being within the abdomen, and then that could identify a leak as well. So yeah, someone's gone straight for it. Yeah, so something doesn't look quite right. Let's look at this view. Let's have a look and zoom in. So I always, yeah, the first thing I do is look at that radial head. Just try and make sure I've had a good look at the radial head on this one. I don't know, you feel like maybe there's a bit of a discrepancy there, but you could almost draw yourself around there. No, I don't think you can really 100% say you could. I mean, maybe there's a bit of increased density located within that area, but not really. I haven't seen anything grossly abnormal there. It's only when you really come up to sort of these views, let's kind of bring that across. You can literally see there's like a chunk. It's like a massive chunk of that radial head that's completely gone. And if we go across to this one for daily radiological or just for storing good cases. So I use it for storing good cases and running my courses. So if you are interested in courses, you can check it out at radiologyseminars.com. And we use it for teaching, really. Conferences use collector minds for quizzes and sharing cases and that kind of thing. I use it for teaching. You'd have to talk to the team about whether it could be used for reporting. I don't know, actually. I don't know. Right, so let's have a look at this, and we can see that, yeah, it's going to be that radial head. That radial head looks like it's got a massive chunk out of it. And so sometimes it can be quite useful to look and see whether we can see where that chunk is gone. And I don't think I can at the moment. I don't think I can. Let's have a look. That one. Yeah, I think it'd be a hard push to find out where this site is. So yeah, it's definitely a radial head fracture. They probably end up do need to do a CT to try and see if there's anything like any more components to that fracture at all. Okay, so I think this one has got a quiz. So let's have a look. So we can put that quiz up while I bring up the images. So this person, I'll just give you a bit of history. This person has had the diabetic, and they've come in with foot pain, and it looks like they've got an ulcer as well, if I remember correctly. So they've done this MRI scan because they are concerned. And so the question is, do we need to give contrast in all cases like this? A lot of you are saying that you do need to give contrast. Fair enough. So, would be quite interested to know what you are looking for when you give contrast. So you can feel free to type in, because we don't always give contrast with these kind of studies. And normally you'd give contrast if you're worried about collection. But actually, when it comes to the idea of diagnosis and that kind of thing, then you actually don't always need contrast, because the findings really are. Oh, hang on, this always comes up. So stop sharing. Let's go. Right. So most people have said to do contrast. Fair enough. Now, when we look at the do I have T1? Do I brought T1? I didn't. Someone put a Q&A question. So necrotizing fasciitis, no, I wouldn't go as far as that, but what we can see here is definitely some increased signal located within the region of the calcaneum. This is also located within the region of the insertion of the Achilles tendon. We can see there's like a partial thickness tear of the Achilles tendon right at the insertion site. I thought I had the T1 weighted images, but it doesn't look like I do, so my apologies. But there was complete loss of the T1 weighted signal as well. And you can see very, very extensive amount of edema extending through to the neck of the talus as well. You can see the plantar fascia doesn't look normal as well. You can see that plantar fascia looks very, very inflamed, looks almost could be discontinuous around that area. So it would be good to have the coronal images, but I don't have the coronal images here. But that plantar fascia looks like it may be discontinuous in some areas here as well. So it could be like a partial thickness tear of the plantar fascia. The articular surfaces, the rest of the articular surfaces look relatively okay. You can see there's a lot of edema located within the muscles as well. So yeah, this is a good, well, not a good case. Nothing's a good case when it comes to these things, I guess. But this is a bad case of oh, this could be the T1s. Why didn't I notice that before? Okay, let's go layout 1 by 2. You can see there's a distinct lack of T1 signal. So when you've got increased fluid signal and a loss of T1 signal, that means that a lot of the fat has been replaced by infection, and therefore this would be pretty much pathognomic for, with or without contrast. You know that that's going to be a significant osteomyelitis because of the lack of T1 signal. We've got a few concurrent findings of this significant Achilles tendon and plantar fascia abnormalities as well. So yeah, that's quite a good and interesting case of osteomyelitis as well. So we don't routinely actually give contrast with the ones that we do around where we are anyway. But that's fine. Everyone does it their own way. Let's have a look at this one now. Yeah, rapid, man. You're in. You're in. Okay, let's have a look. Okay, so this is an X-ray, and this is an adult patient. There are no growth plates here. And at first, you may think, okay, everything looks okay. Let's get my pen out. Let's draw along. So we draw along like so, draw along like so. And it's just around here. It looks like there is a bit of a discrepancy. And if I point it out here, can you see that? That doesn't look quite right. So for a time, people used to feel as though that must be an avulsion fracture from the fibula, but that's actually, you kind of got a joint capsule. And it just happens that sometimes the joint capsule ends up pulling away some of the bone in specific kinds of injuries. And often, like someone says, it can actually be that can be an indicator of an ACL tear. So what we'll do now is go straight across to the MRI scan of the knee, and I'm bringing some MSK to the table for a change, and let's have a look here. So this is a very, very good sequence for looking for most things, right? Fluid sensitive sequences. Let's scroll through right from this side and have a look. So what I always say is that the medial meniscus should look like a bow tie, but like a bad bow tie. So if I was James Bond, I wouldn't be very good at doing my bow tie. Probably the anterior bit would be slightly bigger, smaller than the posterior bit. It would be like that. So that's like an Imran Lasker, not so great bow tie. But if you go to a proper James Bond bow tie, it would be this one where it's kind of completely equal, very, very nice looking, something that Timothy Dalton, who's clearly the best James Bond, would have. So this one looks like you've got a large posterior and a small anterior. So that doesn't look like we can see a definite tear per se, but as you come across, you can see there's some edema located within the posterior aspect of the medial tibial plateau. Coming further along, you can see some bone marrow edema located in the posterior aspect of the Roger Moore. Really? Okay. Fair enough. We'll agree to disagree. Posterior aspect of the lateral tibial plateau as well has got some bone marrow edema. And we've also got some bone marrow edema located within the middle third of the lateral femoral condyle. So bone marrow edema there in those areas that I've just said. It has to be a pivot shift injury. We've also talked about having a Sagon fracture. Then when you look at the ACL, it looks very, very abnormal. I was actually talking to a colleague in Australia today, and he was actually saying, depending on the indication, he actually specifically changes the protocol that he does for the scan. So if there is a potential of the person being an ACL injury, we'll actually have like kind of oblique and a slightly more oblique scan of this, like a sagittal oblique and a slightly more sagittal oblique to get the ACL in plane, which is really interesting. I'm not really seen that like in the UK anyway. We just do a kind of a sagittal and we kind of move on. But he was, I guess he was dealing with athletes and stuff. It's quite important to know how much the tear and where the tear is when they go in. But the PCL looks okay. And then I wonder if we go to the coronal images, we'll be able to find that fracture in the first place. So let's scroll through. And then, yeah, can you see that? That thing over there, you can see there's a bit of a fractured fragment located within that region, coming right off that sort of lateral aspect of the lateral tibial plateau. So yeah, this is like almost you once you see one thing, you look for the next thing and look for the next thing. The other things you want to look for with ACL tears is where there's an MCL sprain, which there is, and sometimes you'll get a medial meniscal tear, and that would become like a Donahue triad or something. So if you have all of those things, but in this one, I think you do have a bit of a sprain of the MCL, but I don't think you can say there's a meniscal tear, but you definitely have unhappy triad, that's right. And then you've also got a complete ACL tear on this one, complete ACL tear, and the bone contusion consistent with a pivot shift injury. So yeah, great, perfect, good. You're rapid on that one. Oh, what happened to my cases? I know they're here. Good. Let's have a look at this one. Yeah, Roger Moore. I've got to say, I remember him when I don't know if I'm giving away my age, but I was pretty young when he was around, and I did enjoy Roger Moore. I did. Yeah, he was good. He was good. Not going to take it away from him. Kind of lost interest in Daniel Craig's version of James Bond after a while. I haven't seen them all. I need to probably catch up with it at some point in life. Right. Let's have a look. Okay, so this is a CT abdomen and pelvis with IV contrast. Looks like it's portovenous phase. I always say we look at the aorta, look at what it looks like compared to the the portal system. That looks slightly brighter than there, so we'd say it's a portovenous study rather than an arterial phase image. And then we kind of scroll through to try and see what could be going on with this patient. So I always do kind of a check. So I have a look at the gallbladder. That looks okay. That could be a source of pain. Look at the pancreas. And the pancreas is kind of this leaf-like structure sitting around here, and that looks okay. We'll look at the renal system as well. Just make sure that scroll. Let's go back to scroll. And the renal system doesn't look like is obstructed either. So yeah, there is some, yeah, exactly. Someone has said something is up with the bowel. So what we need to do is try and figure out what's going on with the bowel. And so one of the systems, obviously, like I've shown most of the time, is just to try and follow the bowel all the way through. But sometimes there's just a quicker way of doing things. So yeah, we could follow the bowel coming up from the bottom here and look, and we can see there's lots of diverticulosis. Follow all the way around, follow it all the way around, and try and see if we can finally get to that area where the small bowel obstruction is. Now, sometimes we're lucky or unlucky for the patient. We can follow the duodenum and try and see where the obstruction is. And that can be a good way to try and eventually get to the point of obstruction. And actually, dilated small bowel is going to be slightly easier to follow than sort of normal collapsed bowel. But the next thing you want to do whenever you get any sort of small bowel obstruction, look for any obvious causes. So you want to look for whether there's any sort of twisting of the bowel anywhere, and also look at the hernial orifices. And the number of times I've had people when I've been teaching them, they'll kind of see the small bowel obstruction and then they'll kind of go through the bowel without actually just going right to the last image. And if they just went to the last image, there was like an obturator hernia, a femoral hernia, or something that was the cause of the entire thing. That's not the cause of this one. But one of the things you can do is when you come up to this area here, can you see that the small bowel is here and the small bowel is here? When you look at the contents of the small bowel, this looks like feces, whereas this looks a bit more liquid. So therefore, this must mean there's a bit of more stasis of fluid located within this area, which has therefore resulted in fluid coming out of it, making it more look like fecal material rather than fluid material. And then when you got that fluid material, that usually will tell you around the area of where the transition is. And if you kind of keep your eye around this area, let's try and see if we can spot. Let's see if I've got my screen thing going. Yeah, we do. Okay, so we've got this one. If we keep our eyes over here, scroll up, scroll up, scroll up. Still over here. Oops, I was being very slow with this. Okay. Okay, scroll up. Sorry about this. Getting all sorts of emojis and stuff as I try and reach across. So you can see around here, it does feel like it gets a bit smaller, a bit smaller, a bit smaller, coming down, and then gets larger, doesn't it? So it's around there. There's something going on, and then it's sort of quite large here. Can you see that there is where there feels like there's a transition point. So you can see the bow, and let's see. Sorry, it's just being a bit jerky right now. I don't know if it's jerking for you guys, but I feel like there's a bit of a transition point somewhere around here. And this fecal sign is a really, really good way. So if you saw nothing else, then I would, when you're reporting it, say there's a small bowel obstruction, haven't identified the exact point of transition, but I can see there's fecal material located within the mid to distal bowel, proximal bowel, and that kind of thing. And that can actually kind of help try and figure out where the problem is. But yeah, single point, not bowel ischemia. Yeah, so I don't think it's going to be bowel ischemia because you can see feces located within there. I don't think you can say convincingly there is air within the bowel wall at all. I think the bowel wall actually looks, I mean, yeah, maybe say slightly hyper enhancing compared to the rest, but it's going to be subtle. I wouldn't really go down the road of this being a bowel ischemia at this present time, but definitely that obstruction is happening around that region. And the fecal sign is a good way when you're on call. I know when I was registrar, I used to really panic when I saw small bowel obstructions, but those three things: look for a quick transition point, look for the hernial orifices, and then look for any fecal material within the small bowel. And if you can't find it, then you're going to have to do this big thing of just going through the entire small bowel. Okay, fine. So let's have a look at this one. And I think there'll be a question for this one as well. And actually, it kind of ties in with what you were just mentioning just now. So now we just need to figure out whether it's adhesion related. Exactly. So that's something you can mention in the report. Has this patient had any previous surgery? This may be secondary to adhesions, and sometimes the clinical stuff doesn't quite tell you. And querying that or calling them up if you can, would be a good idea to try and find out. Okay, so causes include all of these except so. Okay, so first off, let's have a look and see what's going on with this patient. What's going on? Scroll through. This is not good. I'm not happy about this. So accept, cause of these accept. So accept would mean that one of the causes I mentioned is not really a cause. You kind of scroll through, you can actually see that it's incomplete study for some reason. Not sure why the whole thing hasn't come through, but okay, we'll just have to go with what we've got. So if we go to number 4, we can see there's air located outside of the bowel, and you can see there's air located outside the bowel, and you can see there's air located within the bowel wall itself. You can see it's almost circumferentially located within this region. So this is very, very concerning because this may be that there is air located within the mesenteric vessels. But let's do the end of the poll. So yeah, so the answer here was actually, I just put that all of these can be cause for pneumatosis. That can be a benign cause in pneumatosis. Then you've got your scary ones with like ischemia and that kind of thing, infection. Diverticulosis is not diverticulitis. Diverticulosis is just like an outpouching, and is not going to be a cause for pneumatosis like this. So the next thing you want to do is try and have a look at the portal vein system and try and see whether there's any air within the portal vein system. And it doesn't look like it. So portal venous system and into the actual liver as well. But it does look like there is some significant free air located within the abdomen and some air located within the bowel wall. Now, I have to try and remember this case because I pulled it off a while ago. And I think this person was they had previous surgery and they came back for oral contrast looking for a leak, and they were actually relatively okay with regards to the air located within the bowel. So it could have been actually ending up as a result of the surgery, whatever surgery it was. So yeah, someone's saying, could it be colonoscopy? Oh, and the liver lesions. Yes, they are. They've got liver lesions. Let's go back. I forgot about those. So where are they? So this person's got a known carcinoma. So multiple liver lesions located within this region over here as well. Yeah, well done. I forgot to mention that. But yeah, liver lesion as well. So this was a known carcinoma. I think they may have had previous surgery in the past as well, and then they ended up giving contrast to see whether there was a lesion. But yeah, sorry about that. Right, so let's have a look at the final case, which has been donated to us. Hang on. Right, so this final case has been donated to us, and what I'm going to do is open it and see. Let's download. So we've got a CT scan and we've got an MRI scan. So let's do the CT scan. So obviously, I really, honest, genuinely, you don't know how much I appreciate when a case gets donated. Actually, I appreciate everything. Like, honestly, you guys even turning up and spending an evening with me is genuinely. So let's have a look at this one. So I'm going to just download this and have a look. By the way, just a quick plug, if anyone is interested, we have recently launched a musculoskeletal community in on radio seminars, and it's a really good thing. I've been using it every single day, and it's just a way to have a bit of community feel when you're doing MSK reporting. I do a lot of teleradiology, and so I find that sometimes stuck on a case, I don't really know what's going on. And it's so useful to have like a crew. Like I've got a bit of a crew now that I can ask questions and yeah, just see what people think and have interesting discussions. And we have similar talks like this, but we go through MSK case. So if anyone out there is interested in MSK, do check out radiologyseminars.co.uk or .com and have a look at the community. And there's a video a little bit about how that works. But okay, let's have a look at the CT scan and see what's going on. So at first it says CT scan. Am I lagging a lot? Yeah, I don't know why. I don't know why. Let me try. Sometimes it happens because of the screen. So what I'm going to do is pull this across to this screen. I'm going to stop my share and then I'm going to share desktop one. Share. Pull that across there. Pull that across there. Hang on. And there's a chat function there. Okay, so do you think you might launch a chess group at some point? That is an interesting idea. That is an interesting idea. So I haven't thought about that actually. We're in the middle of actually trying to launch a neuroradiology group and neuroradiology MSK neuroradiology fellowship very soon. That should be coming up soon. And yeah, I've never thought of a chess one. Actually, yes, I have. I was recently speaking to a professor. I can't remember to say, and he runs a sort of a fellowship to do with chest imaging, and we were discussing potentially working together and using what we've done with the MSK group to do a chest one. So actually, yeah, that is something that could be in the line and coming up, and probably like early next year. I've got to talk to him again and see whether he's really up for it. But join the mailing list, and we'll be letting you know about that. We try and put our stuff on radio on Collective Minds, but we also have our own mailing list on Radio to Seminar. So do sign up for that, and you'll be told when things come up. Right. So let's have a look at this. Just let me know if I'm still lagging. Let's see, because I've changed the screen now. So okay, let's have a look. And so this is a CT scan of the head, and scrolling through. At first, I don't think I've seen the grossly abnormal here. Okay, so then what you want to do is scroll through these, see if we get stroke windows. Stroke windows, oh, it's not the greatest stroke windows. I don't like these stroke windows, whatever these are. So I'm going to slightly change it. Try and see if there's any sort of loss of gray white matter differentiation anywhere. God, I remember when I first started doing radiology and someone showed me stroke windows. I was like, I don't know what you're doing, man. That's you just made the picture so much worse. But yeah, things have moved on a bit now, thankfully. Okay, so let's have a look. So yeah, I haven't seen anything in terms of loss of gray white matter differentiation on this. I mean, you could say maybe a bit of hypodensity adjacent to the ventricular systems over here, but nothing major to worry about there. So then you've got to start looking at check areas. So you've got to look at your posterior fossa contents, and that looks okay. You want to look at your skull base because you sometimes miss fractures. And I think we've had cases in the past where you've had like condylar fractures, facial bone fractures, and that kind of thing. But I think we're okay here. It's only when you go to the soft tissue windows and have a look at these orbits, there's something very abnormal located. Yeah, exactly right. Right over here. This doesn't look right at all, does it? This looks like there is some abnormal mass located within that region over there. So we do have an MRI scan. Let's see, we've got a coronal view. Is that coronal view? Let's see what's going on here. So let's scroll all the way through. Oh, it doesn't go right to the orbits. Okay, let's go here. Oh, this looks like it does. Yeah, look at that. Look at that orbit there compared to that orbit there. That looks very, very abnormal, doesn't it? It's very, very inflamed. Probably some edema, maybe affecting one of the rectus muscles or something. Rectus muscles there. No. So the rectus muscles look like they're separate from this. You've got one, two, three, four. Yeah, and then there's this weird looking mass located within that posterior aspect there. Okay, let's have a look if we can find some more images of this. So it's separate. What is causing any ptosis? So someone told me a while ago that you draw a line going along like this and see how much the eye pops out. I can't remember the normal values from the top of my head. But surprisingly, I don't think it's really pushing the eye out all that much. There's definite mass located within that region there, isn't there? Okay, let's have a look vessels wise. So it's not like one of those aneurysm vessel things because that actually looks okay, doesn't it? So we have been told that this is something called, does anyone know before I say it? GPA, granulomatosis with polyangiitis, and it's an orbital manifestation. So this looks like you can basically get masses located on the orbit, which can result in proptosis and all that kind of thing. And so this is, yeah, a phenomenal case of it. And yeah, honestly, this would be a good one for teaching and stuff because it's that good, I think. So yeah, cool. So I think that is the end of all the cases that I had. Let's go back and have a look. Yeah, that's all the cases that we had. We've come up to the full hour. So sorry if it's been a bit laggy today. I'm not sure why. I have changed my internet, but it's meant to be like even faster, super duper internet. Sir, differential diagnosis, what do you feel? What do I feel? Yeah, I don't know. I mean, in radiology, because I'm not a neuroradiologist, what I would do is say that there is an orbital mass. I would bring up the potential because um, it's not the rectus femoris. It's not the rectus. I keep saying rectus femoris. You know, I'm an MSK person, really, isn't it? But I would say that there's clearly a mass located within that region. I would bring up the potential of this being a this GP and orbital masses, but I would just refer to the ophthalmologist and see what comes up. Cool. So I think that's going to be it from me for this month. As always, as someone said, orbital pseudotumor. I'm going to look that up. But yeah, thank you so much as always, and I really really appreciate it. And yeah, hopefully I'll see you in the next month. And do give you feedback. I really really appreciate it. Tell me whether it's not good. And did anyone see my Radiopedia talk last week? I did a Radiopedia talk last week, and I really pushed. I feel like I pushed the boundaries, trying to make it entertaining, and I hope it went okay. But yeah, let me know. And I guess I'll speak to you guys soon. And I'll hand back over. All right, switches between you, and my dad. Yeah.
Okay, thank you, Imran, for a great session. And thank you to Hussein Duril for that last donated case that Imran went through. I'm just going to post the survey and feedback form into the chat just now. Please do fill that in. Your feedback is much appreciated and we'll be able to get you a CPD certificate from the back of that. You will also get the link via email as well. So if you miss it in this chat, you should receive an email as well, as long as that you've signed up to this webinar today. How can you get a subscription to CM? So you can sign up for free at cmrad.com. As long as you're a healthcare professional, radiology healthcare professional, and you can just show some ID and proof of that, you can have a free account, and that gives you access to the cases we went through today, and also an additional, I think, just over 4,000 cases, which we have in the global community, varying from all modalities. So you can definitely sign up on there. But what I'll do, Anmal, I'll send you a separate email after this, giving you some further instructions on how to sign up. Okay, thanks everyone, and have a great evening.